We will also try to compare and contrast the clinical presentation of benign and malignant skin and subcutaneous tumors. Okay, so this lecture is mainly about what are the clinical features of benign and malignant skin lesions, what is the etiology of skin lesions in general, particularly the benign, the malignant ones, and what is the clinical presentation. Okay, we will not talk about the investigation and treatment, as the perspective of this course is mainly about the clinical features. Yes, I will try to raise my voice as much as I can. Yes. So as a warming exercise for this lecture, I want to show you this diagram, which is a sketch section from the skin. Just a couple of questions. Now, what do you think? Type of cells? What type of cells lie here?
Squamous.
Stratified squamous.
The type of epithelium is squamous epithelium, and the cells are keratinized cells. Keratinized cells. And what do you call this? What do you call this layer?
Dermis layer.
Dermis.
How many layers form the dermis?
Papillary reticular.
Yes, papillary and reticular. Papillary the superficial, reticular the deepest part. And what is this area?
Hypodermis.
Hypodermis or subcutaneous tissue.
This is the subcutaneous tissue. You know, this is fat. You know, this is what? This is fat. So fat usually occupies the subcutaneous tissue. Okay, and as you can see, there are many structures. There are many structures which traverses these two layers. So you get blood vessels here, capillaries and venules to supply the dermis. But we don't see blood vessels here, by the way. No, we don't see blood vessels in the epidermis. So how do you think the epidermis is supplied by nutrients?
It's avascular.
Yes. How is it supplied by nutrients? The cells are living cells. Keratinized cells are living.
ما papillary junction يا دكتور من الريتيكولار layer حقت الريتيكولار layer اللي في الديرمس ما papillary junction.
Yes, by diffusion. I would say that it's by diffusion. The supply of the epidermis is by diffusion from the layer here beneath it, which is the dermis. Yes, Abandar. Yes, here you can see here we have got this structure, which is traversing the whole length of the skin from the dermis and epidermis, and this is the hair follicle. And this is the hair, and this is the hair follicle. Adjacent to these hair follicles, we have got this structure which are known the sebaceous glands. These glands sometimes can be obstructed, and they give rise to skin swelling, as I will show you in the rest of this presentation. Okay. Yes. So skin tumors in general are classified into benign and malignant. Skin tumors are generally classified into benign and malignant. Or they can be, and the benign can be further classified into neoplastic, like nevi and warts, and inflammatory, like for example biogenic granuloma or epidermoid or inclusion cyst or cyst or epidermoid cyst. Okay. These are examples of benign skin swellings. Okay. Nevi and warts, these are benign swelling that can be encountered in the skin. Sometimes they appear as dark black swellings, okay, because of increased amount of melanin, and there are also other swelling like those which are known as moles and freckles, moles, and freckles. Also types of skin swelling in which there is an increased amount or either in the number of melanocytes. Okay, Pyogenic granuloma is actually a granuloma which usually happens due to trauma, repeated trauma actually. And because the causes is repeated trauma, usually these are encountered in areas which are subjected to repeated injuries, like for example the fingers, like for example the fingers. I will show you a picture in a minute. Epidermoid cyst is another example of a skin tumor. It have got two etiologies. Either it can happen due to inclusion of hair into the subcutaneous tissue, which results in formation of this swelling. This is known as inclusion cyst. Okay, or it can be sometimes it can be congenital. Sometimes can be congenital, and this usually lies in the midline. Usually lies in the midline of the body. Sebaceous cyst, as I have mentioned, yes, Ali. Sebaceous cyst. I have shown you now in the sketch of the skin of the skin that the sebaceous gland. When the part of this gland is obstructed or occluded, then you get a sebaceous cyst, which is characterized by the presence of a punctum or opening at the dome of the swelling, and I will show you a picture in a minute. Okay. This is a wart or a nevus, or it could be a mole or a freckle. And as you can see, the color is dark. This is because the amount of melanin here is high, or the number of melanocytes is also increasing. You know, melanocytes is one of the type of cells which lies at the basal layer of the epidermis. Ali, do you have any question, ya Ali?
دكتور يعني هذه نيفس أو وورت.
Yes, it can be nevus or wart, and sometimes can also be named as mole or a freckle. Mole or freckle. A mole is actually a skin lesion. Yes, a skin lesion in which the amount of melanin is increased. While in the freckle, the amount of melanin is normal, but the number of melanocytes is increased. Now, tell me what is this? According to what I have mentioned, tell me what is this? What do you think it is?
Sebaceous cyst.
Sebaceous gland, yes, or sebaceous cyst. Why do you think this is a sebaceous cyst?
Hair.
There is a hair follicle.
You see this? You see this opening?
Obstructed.
This opening at the dome of the top or part of the
Yes.
This is the punctum. Yes, this is the punctum. This is the punctum. Any swelling which contains this punctum. So this is most likely sebaceous cyst or sebaceous gland. Now, what do you think about this? This is an inflammatory mass. No, it looks like inflammatory.
What?
This is a granuloma. This is actually a granuloma. This is a biogenic granuloma. As I mentioned, this usually happens in the fingers because the fingers is a site of repeated injuries. You can get repeated injuries in the fingers. Okay, so this is classically this is a biogenic granuloma. So these are three examples. These are three examples of skin swellings: warts, moles, freckles, and nevi, sebaceous glands or sebaceous cysts, and biogenic granulomas. Okay. Now, regarding the malignant skin tumors, of course, regarding the epidemiology of these tumors, they are common, and one of the explanations for that they have good association with cancer. In this common type of cancer in humans, these skin tumors in general. And in the USA, actually, the skin tumors are very common, and usually they report to the hospital in very large numbers annually. And there are three types actually regarding skin tumor that I will cover in this lecture: basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. Okay, so these are the three common cancers which I will cover in this lecture. I would like to know the tissue of origin of each one of these tumors. We would like to know also the clinical presentation of and types of each one of these, the risk factors, because these are important, because they have to be surveyed in the history, and what are the important clinical presentation regarding the physical examination. Let us first of all start by basal cell carcinoma, and as you can see here, these usually arise from stem cells or pluripotent cells, which lies usually in the basal layer of the epidermis and hair follicles. So this is the site from which basal cell carcinoma usually arises. And basal cell carcinoma is the commonest skin cancer. Okay, basal cell carcinoma is the commonest. It's much more common than squamous cell carcinoma and even malignant melanoma. Okay, and there are certain risk factors. There are certain risk factors for basal cell carcinoma, and actually the risk factors are more or less the same for most of skin cancers. Okay, so one of the commonest or the most important risk factor is the ultraviolet light coming from the sun. Ultraviolet light coming from the sun. So, fair skinned people or light skinned people who expose themselves, for example, for sun patches in beaches, for example, or who work in areas in which they expose themselves to the sun for long times, okay, are subjected, for example, to development of basal cell carcinoma. Okay, so it's common in fair skinned people who work, as I mentioned, for long times exposed to the sun. And because this type of cancer has relation to the sun, it happens usually very close to the equator, if you know the equator. اللي هو خط الاستواء. Okay, because sun there, exposure to sun there is high. Now, one question here: why do you think this type of cancer is more common in fair skinned people rather than dark skinned people? Any explanation for that?
ميلانين دكتور.
الميلانوسايت دكتور.
Yes, what does melanin do?
protect.
Absorb the ultraviolet.
Yes, it reflects away from the skin. It reflects ultraviolet light away from the skin. That's why melanin is actually protective. Melanin is actually protective against development of skin cancer in relation to exposure to sun. So people who are dark or fair, who are fair skin or white people in general, they are more subjected to development of that. In other occasions, the risk factor is exposure to chemical carcinogens. Exposure to chemical carcinogens like hydrocarbons and so on. Those people, again, who work in the chemical industry, they are prone to develop this type of cancer. Ionizing radiation, exposure to ionizing radiation, because what does ionizing radiation do to the skin and to probably to other tissues?
Destroy lipid bilayer.
It actually it destroys or injures the DNA, the dinucleic acid, DNA. It causes damage to DNA, and this damage to DNA, the cell develop mutation, and then it can turn into malignant cell. Sometimes there are certain genetic factors which predispose the patient for development of skin cancer. Okay, so these are the most important risk factors, and these factors has to be surveyed in the history of any patient who's suspected to have skin cancer. You have to ask about this, whether the patient is being exposed to sun for long times based on his work, job, or based on he goes for leisure time in beaches, for example, for exposure to long time. Whether he works, for example, in chemical carcinogen, chemical industry, exposed to chemical carcinogens, and the rest of these things. Okay. There are two types of presentation of basal cell carcinoma. It's either nodular or nodulocystic. Nodular, it means there is a swelling which is mostly firm. Sometimes part of the swelling might be nodular and part of it could be cystic. This is known as nodulocystic. And the male to female ratio, actually the ratio is higher in the disease is higher in males than in females. So basal cell carcinoma, epidemiologically, I have mentioned that it is the most common skin cancer, the most common skin cancer, and the other thing that it is more common in males than in females. Now, clinically, this tumor is characterized by that it is slowly growing tumor, locally infiltrating and destructing. So it does not metastasize like other tumors, like for example, malignant melanoma. What does it do? It erodes locally the underlying tissues and the neighboring tissues. Okay, and that's why it has been named as a rodent ulcer. Rodent ulcer. So what does it do to the tissues around it? It just destroys the tissues like a rodent, for example, erodes similarly. Okay, so the name rodent ulcer because this tumor tends to destruct and infiltrate locally. Okay, metastasis is very rare. Metastasis to regional lymph node and distal metastasis is very rare in basal cell carcinoma. Okay, and this tumor usually happens in a triangle or in an area, and this area is above line which moving across the mouth. Okay, so a line moving across the mouth, splitting the face into two halves, into two parts. The first part is the including the lip and above, upper lip and above. So any swelling in the face above the upper lip, this is most likely a basal cell carcinoma. This area is known as the basal cell carcinoma triangle, a line joining the angle of the mouth to the nipple to the ear, a line joining the angle of the mouth to the ear on both sides, to the ear pinna on both sides. Okay, so 90% of basal cell carcinoma, 90% of basal cell carcinoma happen above this line. Okay, is that clear يا شباب؟
Yes, clear. Thank you.
اللي فوق الابر يعني على طول.
Yes, a line joining an angle of the mouth, the ear pin on both sides. 90% of basal cell carcinoma lies above this line, in the face above this line. Okay, this is known as the basal cell carcinoma triangle. Basal cell carcinoma triangle. I will show you some picture now, but before that, in the clinical examination, we have got a question now in the OSBI about the type of ulcer. If the basal cell carcinoma ulcerated, which type of ulcer it gives rise to? Which type of ulcer it gives rise to? The basal cell carcinoma.
Rolled ulcer.
Yes, rolled. The typical edge in basal cell carcinoma is rolled, while everted is typical of squamous cell carcinoma. Everted is typical of squamous cell carcinoma. In addition to this rolled edge, there will be rounded, small rounded structures like this, which lies on top of the edge. So, like beads, small rounded like beads. So it gives rise to a characteristic appearance which is known as pearly swelling. Okay, so you get these rolled edges like that, and there are very small structures like beads, which are found on these rolled edge, and the color of these small rounded beads is like diamonds. Okay, I will show you a picture now, and this characteristic feature or presentation or shape is known as pearly shape. So whenever this word comes in the setting or in the context of skin cancer, when you get this word pearly, then the diagnosis is most likely basal cell carcinoma. Okay, usually it happens in the face, as I have mentioned, and it tends to erode through the skull bones into the cranium. It tends to erode through the skull bones into the cranium. Okay, yes. The clinical features of basal cell carcinoma, and here I can show you here these swellings. Yes. So, can you describe what you see here?
swelling
Here there's
and there is a
ulceration.
small
There's
cut.
ulceration. Here there's ulceration in the center here, and this is the raw edge surrounding the ulcer, and we can see shiny. We can see here shiny small peats or rounded structures like that. This is what we call the peats or the pearly surface or the pearly surface. Okay, so swelling like this is
دكتور
most likely.
بيتس يعني BED.
يس بيتس يعني زي حبة الخرز كده تقريبا زي حبة الخرز يعني حبيبات يعني حبيبات صغيرة تمام. Yes. Here this is another, you can see this is where did this lie? Lies above the eye. This is within the triangle of the basal cell carcinoma. So most likely this is a squamous basal cell carcinoma, and you can see also the shiny color. This is again, and this actually could be nodulocystic actually, and this again another example. This is a swelling in the nose. This is swelling in the nose, and this is these ulcers are above the upper eyelid. Sorry, above the upper lid, and this swelling lies in the lower eyelid, in the lower eyelid. Okay, so as you can see now, all this swelling happens above a line, which, as I have mentioned, joining the angle of the mouth here to the ear, on both sides, from here and from here. Okay, so any swelling above this line, is most likely basal cell carcinoma. Okay, yes.
يعني الدكتور كل هذه basal cell carcinoma البيكتشرز.
Yes, all these are basal cell carcinoma. The second type of skin cancer is squamous cell carcinoma. Carcinoma, and this usually arises from the keratinized cells of the epidermis and its appendix. From where does, just to remind us please, one question for you, from where does basal cell carcinoma arises? From where does
From
basal cell carcinoma?
From the basal layer of the epidermis.
Yes, from stem cells or pluripotent cells, cells which had the capacity to divide. Okay, basal striata and striata spongiosum probably. While in squamous cell carcinoma, the tumor arises from keratinized cells in the epidermis and its appendix. Okay. Basal cell carcinoma is the most common type of cancer, and squamous cell carcinoma is the second most common skin cancer. Okay, and the ratio again, like basal cell carcinoma, the ratio again in male is the disease in male is more than female. For a ratio is almost 1 to 3. A ratio is almost maybe 1 to 3 or something like that. But anyway, the disease is more common in male than in females. As you can see, the risk factors for squamous cell carcinoma is almost like the same for basal cell carcinoma. So again, we have the ultraviolet light, the ionizing radiation, the chemical carcinogens. But here there are certain things to be mentioned. Squamous cell carcinoma can happen in patients who are immunocompromised. So patients who have got, for example, who are receiving, for example, immunosuppressant drugs, like for example, patient who underwent renal transplantation, we give them immunosuppressants for a long time. They will be predisposed to the development of squamous cell carcinoma. Okay, or patients who receive chemotherapy, for example, patients who have got cancer and receive chemotherapy, again they can develop squamous cell carcinoma because the immune system have got an important role in prevention of skin cancer. So when the immunity reduces or decreases, the patient will be predisposed to skin cancer in general, particularly squamous cell carcinoma. Also, chronic osteomyelitis or scars in general. The patient can develop squamous carcinoma on top of a chronic scar, chronic osteomyelitis, like that. Okay, And squamous cell carcinoma developed in an old scar or a sinus of chronic osteomyelitis. This is known as margarine ulcer. This is known as margarine ulcer. So what's margarine ulcer? Margarine ulcer is a squamous cell carcinoma developed on long-standing scars or chronic osteomyelitis. Okay. Also, there is some relation between squamous cell carcinoma and smoking. The disease is reported to happen at higher rate in smokers, and there's also some relation to infection with human papillomavirus (HPV). Okay, so these are the most important risk factors for squamous cell carcinoma. So patients again who are exposed to sun for long times, like those who are fair skin, who works in exposed to sun for long times, or those who go to exposed to some patches in the beaches and so on, all of them are exposed are predisposed to development of skin cancer. The clinical features. Now, what do you think about the type of the ulcer here? The type of the ulcer is everted. Yes, yes. Any explanation? Anyone can explain why the edge of basal cell carcinoma is while the edge of squamous carcinoma is everted like this? Any explanation for the edge in squamous cell carcinoma and basal cell carcinoma? Why the edge is looking like this in squamous cell carcinoma, while it looks smaller actually in basal cell carcinoma? Did you think of that?
Due to the growing direction of the squamous cells.
Yeah, here we have got malignant cells which are rapidly dividing, Okay, so that will result into in this mass, and the mass will continue increasing like that and projecting outwards because of the rapidly dividing cells, malignant cells. In case of squamous cell carcinoma, okay. In case of basal cell carcinoma, why the edge is not like large or big like this in case of squamous cell carcinoma? It looks smaller, no?
دكتور البيزل سيلز اللي يصير لها growth.
Yes, because growth is mainly going to deep. As I have said, the tumor tends to invade deep structures, and there is no rapid division of malignant cells at the edge. Okay, and the tumor is slowly growing in comparison to squamous cell carcinoma. So all these reasons explains why the edge in case of basal cell carcinoma is rolled, while in case of squamous cell carcinoma is everted. Is that clear?
Yes, clear. Thank you.
Okay. Now, I have said that basal cell carcinoma is locally infiltrating and it does not metastasize usually to distal areas. And actually, in squamous cell carcinoma, the rule is actually the opposite. And squamous cell carcinoma tend to metastasize to regional lymph nodes very early. Okay, very early. So this is one main difference between basal cell carcinoma and squamous cell carcinoma, that basal cell carcinoma does not metastasize almost never, while in case of squamous cell carcinoma, it can metastasize actually very early, particularly to regional lymph nodes, Yes, here are some pictures. Of patients who have got squamous cell carcinoma. Yes. What do you think the diagnosis here? If this patient is having a squamous cell carcinoma, what do you think the diagnosis here?
Squamous cell carcinoma.
Yeah, but it looks like it's happening over abnormal skin, no? Surrounding skin looks
chronic ulcer.
Yes, this patient might
Venous, maybe.
This patient might have bare. He might have a bare wound, or he might have a wound of chronic osteomyelitis. Now, on top of this, we get this ulcer. So, what do you think now the diagnosis here?
marginal ulcer.
Yes, this is most likely a margarine ulcer. This is most likely a margarine ulcer. Why? Because it is developed on top of a scar. It is developed on top of what? On top of a scar. So any squamous cell carcinoma happens on top of a scar. This is a margarine ulcer. We call it a margarine ulcer. Okay, and here you can also see here. This is not clear, not quite clear, but the skin here looks like what? Like black and contracted. So this is most likely again what? Yes, this is again this is a margarine. This is again a margarine ulcer because it looks like it's developed over what? Unhealthy skin or a scar or something like that. Okay. This is a nodular type of a squamous cell carcinoma. Nodular type of carcinoma. Okay. And now, if basal cell carcinoma happens mainly, in the triangle in the face, where does squamous cell carcinoma is usually encountered? Any answer?
Below the triangle, anywhere lower limb side.
But particularly where? Particularly in sun exposed areas. Particularly in sun exposed areas of the body. So I'm talking about the head and neck. I'm talking about the upper part of the trunk, shoulders. I'm talking about the limbs. Okay. So the tumor usually encountered where in sun exposed areas. So usually areas which are covered by clothes, not directly subjected to sun rays. Usually tumor don't happen here. Happen in sun exposed areas. Okay, that clear? Yes. Before we talk about malignant melanoma, I need one of you just to summarize. The differences between basal cell carcinoma on one hand and squamous cell carcinoma on the other hand. Anyone can summarize the main differences, only the main differences.
Yes, regarding to basal cell carcinoma,
Yes.
it more occur in the triangle in the face above the line, and regarding to squamous cell carcinoma, other than the triangle and then the sun exposed area.
Yes. This is one thing. Yes. What else?
This is ruled or rodent ulcer, and this is everted, the squamous.
Explain. What do you mean?
I mean the edge of the squamous cell carcinoma will be everted due to the highly splitting cells over the skin. And regarding in basal cell carcinoma, the dividing cells will be down. So
Yes,
this
so-
makes it ruled.
Okay, so the first point, the first aspect of difference, you talk about the site of each one. Now, I want you to comment on the nature of growth and spread. Nature of growth and spread.
The growth of squamous cell carcinoma is very high, very fast, but basal cell carcinoma is not.
Yes, so basal cell carcinoma is locally infiltrating, only locally infiltrating and destructing. While basal cell carcinoma, while squamous cell carcinoma tend to metastasize to regional lymph nodes and nearby structures. Yes. The other difference in the clinical examination in the shape of the ulcer. As you mentioned, the ulcer in basal cell carcinoma you have got a rolled edge, while in squamous cell carcinoma have got an inverted edge. Okay. Any difference regarding the etiology?
Mostly the same, but basal squamous cell carcinoma come with the immunocompromised patient.
Yes. And can also happen over scars, long-standing scars, and they can also happen with infections like human papilloma viruses. Okay, so there are some differences, but sun exposure and chemical carcinogens and genetics also play a role even in squamous cell carcinoma. Okay, so these are the main differences between squamous cell carcinoma and basal cell carcinoma. The third type of skin cancer that I would like to cover here is malignant melanoma. Of course, there is also difference between basal cell carcinoma and squamous cell carcinoma regarding the tissue of origin or cells of origin. I think we already have mentioned that. Malignant melanoma actually arises from melanocytes, as the name indicates. So mostly these swellings or tumors appear as black. However, some melanocytes does not have color. Some melanomas does not have color. Okay. Regarding the order of commonality in relation to other type of skin cancer, malignant melanoma is the least common skin cancer. Malignant melanoma is the least common skin cancer, so the frequency of the prevalence of this cancer is less than basal and less than squamous. However, despite this low rate, this tumor is responsible for 75% of deaths in patients with skin cancer. Okay, so despite that it is the least common skin cancer, the mortality of this tumor is very high, and it's actually approaches 75% of all of patients having skin cancer. So what does this information tell you? I mean, what does if it is the least common and at the same time it is the most lethal? It is the most lethal.
Very aggressive.
Yes. So the information that we can conclude here that it is very aggressive. It's very aggressive tumor because it tends to metastasize very early, and sometimes at the time of diagnosis, the tumor has already metastasized to distant structures. Okay, it happens more commonly in young adults. It happens more commonly in young adults in comparison to elderly and patient and children. The risk factor, again here, it can happen de novo in normal skin due to exposure to ultraviolet radiation, and also the patient has good genetic predisposition and so on. And sometimes it can happen in preformed nevi. Okay, so if you have got a nevus, then you can, this nevus, there is a risk of malignant transformation in this nevus, and it can turn into a malignant melanoma. So again, there is also relation with genetic, and there's also relation with immunosuppression. Okay, so as you can see here, more or less, the etiology or the risk factor for skin cancer are more or less the same among all types, whether basal or squamous cell carcinoma, or in case of malignant melanoma. Okay. Now, if you saw a patient with if you meet a patient with malignant melanoma in the hospital, you look at the lesion, the tumor itself, then there are three possibilities, or there are three types. Okay, the first one is known as superficial spreading, and here the swelling is not nodular. I mean, it's macular. Okay, no nodule or no bulge from the skin. Okay, and actually this is the most common. Type, accounting for 75% of all types of malignant melanoma, superficial spreading. Okay, and this can happen usually in a preformed nevus. Okay, the other type, which is around 15%, is nodular type. I will show you pictures of this in a minute. Okay, but first of all, I will just inform you about these types. So the first one is superficial spreading. The second one is nodular type. Usually happens in the trunk, in the head, or in the neck. The third type is known as lentigo maligna, accounting for 5 to 10%, usually giving rise to crown macules. And acral type. The acral type is characteristic happens in soles and feet and palms. Okay, acral types accounting for only 2 to 8% happens usually in the soles and in the palms. Okay, so any blackish swelling in the soles or palms, it can be what it can be a malignant melanoma. And at that type, the type of malignant melanoma is usually acral. We have got another type. I have mentioned earlier that in malignant melanoma usually the color tends to be dark or black, and this is because of the amount of melanin inside the tumor. However, some melanomas they don't have that black color, and they are named as amelanocytic. Amelanocytic. A means no, and melanocytic, and this terms means no melanin. So you don't see that black color, which you can see also in other types. Okay, there is also a very characteristic type of malignant melanoma which happens in under the nails, And what do you call this type? We call it subangle. We call it subangle. I will just try to write it here for you. Subangle. Yes, subangle. As you can see here, subangle. This is a type of malignant melanoma that happens where in the nail bed. It happens in the nail bed. Okay. So a patient usually have got a black lesion in the nail, black lesion appearing through the nail. It could be a malignant melanoma of the subangle type. Okay. This in relation to what I have mentioned just in a minute, that a patient can present with this black swelling. As you can see, it's destructing the nail, destructing the nail. So what do you call this type of malignant melanoma?
Subangle.
Yes, some patients might present with dark nail like that, which can be due to a sign like this benign racial melanonychia. Okay, and this is a benign lesion or benign appearing can happen in certain population due to genetical factor. This is benign. Okay, so how can you differentiate? Sometimes the patient can have a trauma, and he can have a hematoma beneath the nail bed. Okay, which also appear like a black color. So how do you differentiate between subangle melanoma and these two conditions? If the patient have got these benign racial, he has a hematoma. How do you differentiate? If you want to
دكتور ما فهمت البناين اللي تقوله.
Now, do you see this nail? This nail here looks like black. You see? Looks like what? Dark. Looks like dark, no? But this is benign. This is benign. This is a sign which is known as happen in certain races. That's why it's known as benign racial melanonychia. If the patient has got trauma, he can develop what? A hematoma. He can develop a hematoma beneath the nail. Okay? Again, it will be like a black color. So the question here, how to differentiate between whether this black lesion under the nail is melanoma, like in this case, or it is due to trauma, for example, or due to another reason or other factor rather than melanoma. How could differentiate? If you want to differentiate, look at the nail fold. I'm talking about this area. Okay? You see this area? This area looks like what here? Looks like swollen. Looks like what? Swollen, and there is what? And the destruction is spreading from the nail, spreading where? Into the nail fold. Okay? So this sign, which is invasion and swelling of the nail fold, this area, is known as the Hutchison's sign. Known as what? Hutchison's sign. So what is Hutchison's sign? Hutchison's signs is invasion, infiltration, and swelling of what? Of the tumor into the nail fold, and swelling of the nail fold like this. Okay, this does not happen with any other other factor which can give rise to a black swelling in the nail. Okay, so if the patient have got, for example, if the patient have got, example, hematoma, trauma due to hematoma, or he is having this type of benign racial melanonychia, the nail fold you see here will be what? Will be normal. But if the nail fold is invaded, infiltrated, and swollen, then this is most likely what? Malignant melanoma. Okay, so the point here actually is that there are many, more than one condition that can give rise to a black lesion in the nail. Okay, there is more than one condition that can give rise to a black lesion in the nail. Okay, how do you differentiate? By what? Examining the nail fold. If you find the nail fold is swollen like that and invaded, looks like invaded by the tumor, then this is a positive Hutchinson sign, which indicate that this is most likely a malignant melanoma rather than any other reason. That clear?
يعني دكتور نختبر النيل فولد.
A nail fold, yes. If you suspect malignant melanoma subangle, if you suspect subangle malignant melanoma, look at the nail fold. If the nail fold is invaded like this and swollen, this is a positive Hutchinson sign, and this will increase the likelihood or the possibility of malignant melanoma. Why? If the nail fold is normal, then this is unlikely malignant melanoma. This is useful, no? And clinically, this is useful because if the patient have got a black color in his nail, it could be melanoma, but it might also be something else. Okay?
واضح دكتور يعطيك العافية.
So look at this now. Look at these lesions. Which type do you think now? Can you mention the type of this? All of these are malignant melanomas encountered in different areas and have got different shapes. So tell me about this, please. Which type of malignant melanoma? This is projecting, you see? You see this is projecting upwards. Yeah, this is nodular, yes, very good. It looks like a nodule. This is nodular here, very clear. So what do you think about this? Here there is no nodule. It is macular. This is macular because there is no nodule here, not macular. But it is look like what? Spreading around. It looks like what? Spreading around. So what do you call this?
Superficial
spreading, which is the most common, no? Superficial spreading, which is 75% of all malignant melanomas. Now, what do you think it is? This is the sole. This is the sole of the foot, and this patient have got this black color, which is a melanoma in the sole of his foot. So, what do you call this? What's the type here? This is acral. Yes, any melanoma in the palm or in the sole, this is acral. And what do you think about this?
melanocyte.
It does not look like black. Yes, this is a melanocytic. This is a melanocytic. Okay, so this is how to differentiate and differentiate between different types of malignant melanoma. Malignant melanoma is highly malignant tumor. It's a highly malignant tumor. It tends to metastasize to lymph nodes very early. And regarding lymph nodes, there are two types of lymph nodes which can be encountered around any malignant melanoma. The first one are small lymph nodes around the swelling. If you, for example, if this is a swelling here, okay. A type of lymph nodes which can be encountered around the swelling, and these are usually named as what? Named as satellite nodules. These are the swellings which are in lymph nodes. They are actual lymph nodes, but they are not the formal lymph nodes draining the tumor. So these are known as satellite nodules, which are found around the primary tumors. And then you found also involvement of the regional draining lymph nodes, which, for example, if the swelling is in the lower limb, then this will be in the inguinal group of lymph nodes. So, for example, if you have got a malignant melanoma in the link, you find small nodules around the primary tumor, and these are known as satellite nodules. And you also get enlargement of the inguinal lymph nodes, and these are the eventually draining group of lymph nodes of the whole lower limb. Okay, so two types of lymph nodes which can be encountered by on physical examination: satellite nodules and the draining group of lymph nodes. Both of them can get enlarged. Okay. So the tumor is highly malignant. It tends to metastasize to regional lymph nodes and to other distant structures, like, for example, the lungs. The patient can present with hemoptysis, or he can present complaining of hemoptysis. Okay, and it can metastasize to other distal regions like the brain, for example. Okay, so the patient can present with features of metastasis very early. And actually, many patients, when they are diagnosed, they are already having this distant metastasis, indicating that the tumor is highly malignant. The tumor is highly malignant. Okay, as I have mentioned that it is one of the main causes of death among patients with skin cancer. Yes, so that was about malignant skin tumors. We have talked about three types of skin cancer. We talked about basal cell carcinoma, we talked about squamous cell carcinoma, and we talked about malignant melanoma. Now, I will take just few slides to talk about some important subcutaneous tumors or swelling. Some important subcutaneous tumors or swellings. I think I have asked you once, maybe in the simulation, in the clinical skills lab, about which type of swellings do you expect in the subcutaneous space. This depends actually on what? This depends actually on the types of tissues that you can encounter in the subcutaneous space. So tell me about the types of tissue which is usually lies in this space, and give me examples of swellings that can be encountered there. If you can hear me.
Muscle.
Sorry?
If it's muscle, rhabdomyoma.
No, muscle does not lie in the subcutaneous. Muscle is considered as part of the deep structures. But I'm talking about the subcutaneous swell between the skin and the deep structures.
Fat. Nerves.
Fats, a deep tissue. Yes. Which type of swelling related to fats?
Again, please.
Which type of tissue is related? Which type of swelling related to fats, to adipose tissue?
Lipoma.
Lipoma. Yes. What other type of tissues that can be encountered in the subcutaneous space?
Fibroma.
Fibrous tissue from which you can get fibroma. Yes. What else?
Nervous tissue, neuroma.
Yes. Nerve tissue, neuroma. Yes.
And
there are also
vascular hemangioma.
Yes, small venules like that. You can get a hemangioma. So these are the sort of benign swellings that you can get in the subcutaneous. Of course, these benign swellings sometimes, occasionally, they can turn into malignant. So what do you call a lipoma which is turned into malignant swelling? What do you call it?
Liposarcoma.
Liposarcoma and sarcoma and so on. Yes. Of course, the most important common subcutaneous tissue in the whole body is a lipoma. The lipoma is actually the most common subcutaneous tissue. It happens both in males, it happens in females, it happens in adults, it can also happen in elderly and so on. Probably this explains why it is very common. It can happen everywhere in the body. Particularly at the back of the neck, in the upper part of the of the back, okay, in the shoulder areas. Sometimes they can be single, sometimes they can be multiple, even they can be multiple. The patient might have more than one swelling in his body, okay. The most important clinical features on examining a lipoma are, because it is benign, usually it will be very well circumscribed, very well circumscribed, because there is no infiltration of nearby structure. It's a benign swelling. And then when you feel it, it looks like lobulated. It feels like there are multiple septi crossing the swelling and giving rise to the sensation of multiple lobules. So you feel it as lobulated, okay? Because it arises from the subcutaneous tissue, it is not neither attached to the skin nor to the deep structures, structures. And there is also a very a test which is very clinical test which is very characteristic of the lipoma, that when you press with the tip of your finger, when you press on the edge of the lipoma, it tends to slip. It tends to slip beneath your finger, and this is known as slippery test, or slipping edge or slippery test. Okay, this test is actually very characteristic of what? Very characteristic of a lipoma. Okay, so I will repeat this again. When you press on the edge of a lipoma with the tip of your finger, okay, sometimes the lipoma might slip beneath your finger, okay, or it move away from the tip of your finger. This is known as the slippery test, or we can say that the edge of this swelling is slipping edge. Okay, this is very characteristic of what? Of a lipoma. Okay, so these are the main characteristic features of lipoma which you can get by examination. Okay, it's well circumscribed. It feels like lobulated, or there are multiple septi on the surface. It is neither attached to the skin nor to the deep structures, and the edge of these lipomas is usually slipping. Yes. These are photos of different patients. These are photos of different patients who have got what? Who have got lipomas. So as you can see here, the lipoma lies where? Can you describe here where does it lie?
In the shoulder.
In the shoulder, or in the scapular region, in the middle part of the scapular region. And here, where does it lie? In the shoulder region here, this is the shoulder region, or the upper part of the scapular region. And here, where does it lie?
In the neck.
Yes, in the back of the neck. And this can be everywhere. This can be everywhere. Okay, so lipoma can be encountered, can happen everywhere in the body. Okay, but if you examine now this, any one of these lipomas.
دكتور بس لو تضغط على علامة السهم لأنه ما هو واضح.
Okay, yes, معلش. This is in the scapular region, in the middle part of the scapular region, and here at the top of the scapular region or in the shoulder area, and this is the back of the neck. Okay, and this can be everywhere. Now, if you examine, if you palpate, of course it looks like well circumscribed. انا ما ادري علي بيرفع يده كله دقيقه، ما ادري في مشكله في فيروس ولا ما ادري في مشكله نفسه، ما ادري ايش اللي حاصل. علي بيرفع يده كله تقريبا كل ثواني، كل 5 و10 ثواني. Do you hear me يا علي؟
اسمعك يا دكتور، اسمعك.
علي انت ترفع يدك كله 10 ثواني، ما ادري في مشكله ولا؟
كل شوي يسوي لي كونكشن يا دكتور من النت شوي.
ها؟ نعم؟
النت ضعيف عندي.
ما ادري هذا فيروس، في فيروس ولا ما ادري ايش اللي صاير، ما ادري.
الدكتور يقول ان النت عنده ضعيف، يمكن عشان الاتصال.
ايوه بس لانه كله 5 ثواني بيظهر له انه فيروس. يا محمد هذا فيروس. الله يسترنا مع الفيروسز هذه. This is the second time for me to encounter such a problem. It could be yes. الله يستر. So just please tell me about now. If I ask you to examine, to palpate this swelling, what do you expect to find? Just to remind me about the most important.
Lupulate.
Lupulate.
Yes.
Slipping.
Yes. Yes.
When the patient fix the muscle, it will not change the range of motion, or if he relax the muscle, the range of motion will be the same.
Yes. So as you can see here, it looks like well rounded, and again, if you palpate the edge will be very clear, distinct, indicating that this is most likely a benign lesion. And then when you feel it, it will look like lopulated, as I mentioned, and then it will feel like what will be the consistency?
Feel like sponge.
Sponge, soft. Right. Can it feel like cystic? Can it feel like cystic? Can some lipomas feel like cystic, like a cyst?
It could be.
How do you explain that? What is the explanation that occasionally a lipoma can feel like a cyst? And if you did even the cross fluctuation test, it might be positive, and still it is not a sebaceous gland. It is a lipoma.
إذا كانت فيها سليبنج دكتور يعني زي الفلويد في بالبيشن.
لا sleeping هذا هي soft sleeping هذا في كل الأحوال. لكن sometimes it feels like cystic rather than soft. Usually it feels like soft, but sometimes it can feel like cystic. So any explanation for this? If you don't mind, I would like to leave it as a homework for you. Try to find out why some lipomas feel like cystic sometimes rather than soft. Okay.
Okay.
Yeah, I like that you develop a skill of searching for the information. I think this is one of the most important that you should learn while you are in the medical college. So we have got two homeworks out of this lecture. What was the first question for you?
regarding the femoral hair.
دكتور الصوت يقطع مرة.
Yes.
ما ادري ايش المشكلة.
يمكن النت بس بيضعف شوية بعض الأحيان. لكن الفيرست question for you was why the femoral canal is larger in female than in males. Now the second question is for you why some lipoma feel like cystic rather than soft, like what we see in most of lipomas. The other benign tumor are neuromas. Usually this is happening in combination of nerve tissue and fibrous tissue. We call it neurofibroma. And this usually happen as multiple lesions. Usually happen as multiple lesions in a disease which is known as neurofibromatosis. Okay, and there is more than one type of this disease. However, when it happens with family history or family predisposition, we call it von Recklinghausen's disease. Disease. Have you heard of this disease before?
No.
Yes. This disease is a genetical one in which the patient develop hundreds or thousands actually of neurofibromas. Hundreds of thousands of neurofibromas. Okay. And also very characteristic on those patients, they develop some skin patches, dark or brown colored patches, which is known as the cafe au lait because their color is very similar to the color of coffee. So look at this picture. On the left here, This patient, can you see how many neurofibromas that he has? Many thousands of neurofibromas. It happens like that. And when you examine their skin, you find patches like this, and these patches are known as what? Cafe au lait. Known as cafe au lait. Usually, those patients will have no, not berbera, cafe au lait. Dark skin patches like that, which is known as cafe au lait. Cafe au lait from coffee, because they have, I think they have their color is very similar to that of coffee. That's why it has been named as cafe au lait. Okay, so the combination of these two, these thousands or many neurofibromas like that. Okay, in addition to this cafe au lait, the clinical diagnosis for these patients will be most likely what? Von Recklinghausen's disease or neurofibromatosis Okay, this is another example of benign skin lesions or skin and subcutaneous lesions.
Is it painful?
Not necessarily, unless it is infected or there is some ischemia in it. But in general, it is not. The last benign skin lesions that I would like to mention in this presentation is hemangiomas. And usually these are benign. Are more common in females than in males. More common in females than in males, and 30% of these are usually present at birth. 30% of these are present at birth. After birth they grow spontaneously, and then usually they involute or disappear in many cases, in most of the cases, by the age of 7 years. Okay, so this is the natural history of this vascular tumors. Okay, they arise in the subcutaneous and skin, and they give rise to characteristic color in the skin. Usually they are present at birth, after which they start to grow slowly, and usually they disappear by the age of 7 years. Examples include capillary hemangioma, capillary vascular malformation, which is known as the port-wine stain, and spider nevi. I will show you pictures. I will show you these pictures. This is known as capillary hemangioma. You see this dark red color lesion. This is known as capillary hemangioma. On the right side, you can see here the red color is diffuse. Red color here is diffuse, as if the skin is stained. As if the skin is stained, and that's why this is known as port-wine stain. Stain, or the name is also, as I have mentioned in the previous slide, as capillary vascular malformation or port-wine stain. And what do you think of this?
Spider nevi.
Yeah, this is very characteristic. The shape is very characteristic of the spider nevi. So these are three examples. Of hemangiomas which can be encountered on the skin. Capillary hemangioma like this, port-wine stain, in which the hemangioma tend to stain the skin like that, in wide area like that, and the spider nevi. So what is important about this is that commonly they are present at birth. They start to grow after that, but eventually 70% of them they involute that and disappear. Okay. Yes. So these are the in the last slides we have mentioned some of the benign lesions that can be encountered in the skin and subcutaneous space. We have talked mainly about the clinical features, etiology, and the clinical presentation of this. So I hope in this lecture We have covered the most important clinical features of benign and malignant skin lesions regarding the tissue of origin, regarding the etiology, regarding the most important clinical features, the most important points in the history that and the most important things to expect in the physical examination of these lesions. Okay, these are that I have displayed at the beginning of the read. And now, if you have any questions regarding benign or malignant skin lesions, please do point to me or directly pose your question, please.
الله يعطيك
Any
العافيه.
questions?
سؤال واحد بخصوص الاوريجن اوف
Yes, there should be some questions. There should be some questions. Yes.
سؤال واحد بخصوص الاوريجن اوف بيزل سيل كارسينوما وسكويموس سيل كارسينوما فاتتني ستيل.
Yes. Yes, albino cell carcinoma usually originate from rapidly dividing cells. We call it stem cells or pluripotent cells. Usually, they are found at the basal layers of the epidermis. These cells usually their function is to replace the cells which are damaged in the superficial layers of the epidermis. They can turn into malignant cells and give rise to basal cell carcinoma. So squamous cell carcinoma, on the other hand, arises from the keratinized cells which are found in the more superficial layers of the epidermis and the appendix. They can also or from the keratinized cells in the appendix of the skin, like hair follicles and so on. Okay. Yes, so basal cell carcinoma from a bit deeper from the level of the squamous cell carcinoma. I hope this is clear.
Thank you, very clear.
Any other question, ya Shabab? There should be some questions. If no question, that means you understand very little. Or you understood a very little.
تيجي المحاضره نقراها بعدين نطلع الاسئله.
You need to understand first, no? طيب ما في أي question جات at your mind at this level? Any question at this level? At this preliminary level?
لا تقريبا دكتور كل شيء واضح ان شاء الله.
Okay, inshallah, I will send you the lectures by today. Inshallah. And I hope also that you find the time to also look in the textbook, Bailey Allah and browse regarding the how to examine and the important clinical features of the skin lesions, benign and malignant. I hope you find time for that. Okay.
يعطيك العافية دكتور.
Now, please, again, raise up your hands for attendance, please. Raise up your hands.
شكرا دكتور، يعطيك العافية.
Yes. Raise up your hands for attendance, please.
Sure.
دكتور أحمد، في طالب اعتذر قال جوالي بيوقف النت وطلع من المحاضرة، قال ما أقدر أكملها. اسمه سامي.
سامي؟
نعم سامي شامع.
اوكي طيب يا شباب، بس عندي بس طلب بسيط. لو عندكم اتندنس شيتس بالنسبه للكلينيكال سيشنز اللي في المستشفى، تمام، ارسلوها لي بالله عن طريق الليدر. تمام
دكتور، في الظاهر هناك شخص يستلم الاتندنس كل مره اذا ما خاب ظني.
ايوه
اللي هو
لو في
نبيل
ميست. اوكي تمام. لو في ورقه ليفت اور ميست مع واحد من المجموعات بالله ترسل لي عن طريق الليدر باي توداي لو سمحت.
شور. تمام.
اوكي. Thank you so much يا شباب and wish you all the best and see you inshallah.
Thanks a lot. Bye.